Welcome to this deep dive. We're jumping straight into a topic that's really critical for anyone in medicine, especially if you're revising, intracranial venous thrombosis, or IVT.
Yeah.
So we've looked at the source material you sent over, basically really good high-yield revision notes on IVT, our mission today, to kind of distill that down, pull out the absolute must-know, memorable bits just for you. Think of this as like your personal study session. We'll highlight the key facts, potential exam questions, maybe some memory hooks, all straight from those notes.
Yeah, and IVT is definitely one of those tricky ones. Clinically, I mean, the symptoms can be so varied, look like lots of other things, but spotting it early is just vital. And luckily, modern imaging has really changed the game, helped us see what's going on much better. So hopefully this deep dive will help clarify that picture for you.
Okay, brilliant. Let's grab those notes then and really get into intracranial venous thrombosis. Let's start right at the beginning, the basics. Based on the source material, what exactly is IVT?
Simply put, it's a blood clot, one that forms within the actual veins of the brain, or in those big venous channels between the brain and the skull. We call those the dural sinuses.
Ah, the dural sinuses, right. So it's different from the usual strokes we think about, the arterial ones. This is the venous system.
Exactly. And your notes point out, while it's less common overall than arterial stroke, it's a real clinical challenge precisely because it can present in so many ways.
Makes sense. If the symptoms are all over the place, then understanding the why, the causes, the etiology seems super important for figuring out who might be at risk. What do the notes say causes it?
Well, there's a pretty long list in the notes, actually. We can kind of group them, though. One category is infections, although interestingly, the notes mention infections plus trauma and tumors altogether only cause about 10% of cases. So infection may be less common than you'd first think for something intracranial.
Huh, only 10% for all those combined.
Yeah. But when infection is the cause, sinus infections, especially frontal ones, are mentioned, and staph aureus is noted as a common culprit there.
Okay, so infections on the list, maybe especially after sinus issue, but it's not the top cause. What else?
Then there's trauma, which makes sense, head injuries, even neurosurgery, and a really big category is hypercoagulability conditions. Basically, anything making your blood clot more easily. Your notes list things like antiphospholipid syndrome, inherited thrombophilias, protein S or C deficiencies, lupus anticoagulant, Leiden factor V mutation. Quite a few.
Right, so issues with blood clotting itself, that seems like a major group. What other categories are there?
There are inflammatory conditions. Think Crohn's disease, ulcerative colitis, SLE, that's lupus, granulomatosis with polyangiitis, Behçet's disease. Also, hematological disorders like PNH, TTP, sickle cell, polycythemia rubra vera.
Wow, okay. A lot of different blood and immune system things can feed into this.
They can. And the list keeps going. Other conditions like cancer, nephrotic syndrome, that kidney disorder, dehydration, cirrhosis, sarcoidosis, and then really important ones, pregnancy, the period just after birth, the puerperium, and using hormonal meds like the oral contraceptive pill. And finally, sometimes the cause just isn't found. Unknown.
That is a lot to take in. For revision, maybe grouping them could help. Like you've got clotting problems, inflammation, infection trauma, and maybe situational, like pregnancy or the pill, might make it stick better.
That's a good way to think about it. And it flows right into the next bit from your notes. Risk factors. So who's most likely to get IVT?
Exactly. If someone comes in, what clues in their history or current situation should make you think, maybe IVT?
So the key risk factors listed are a personal or family history of clots, being pregnant or recently postpartum, using hormonal meds like the pill or HRT, also having certain medical conditions, cancer, autoimmune diseases, kind of linking back to the causes we just talked about, and of course, a recent head injury or brain surgery.
That list feels really practical, like a mental checklist when you're seeing a patient. Maybe linking each risk factor back to why it's a risk, like the pill affecting clotting, could be a good memory aid for you.
Absolutely. Understanding the why behind the risk is key.
Okay, so we know what it is, the potential causes, who's most at risk. Now the mechanics, how does it actually happen? What's going on inside those veins? The pathophysiology section in the notes.
Right. Your notes boil it down to three core things, basically. Blood hypercoagulability, the blood's too clot prone, then endothelial damage to the vein lining, and stasis, blood flow slowing down in the veins. Those three together, that's the perfect setup for a clot.
Sounds a lot like Virchow's triad, but specifically in the brain's veins.
Pretty much, yeah. And the result. The clot blocks the veins, so blood can't drain properly from the brain. It gets congested, pressure builds up, and your notes highlight the consequences. This backup can lead to, well, serious stuff like cerebral infarction brain tissue dying from lack of blood flow, even though it's venous blockage, it affects the small vessels, and also hemorrhage leading into the brain.
So the blockage causes the damage downstream, or rather upstream. And you said earlier where the clot is really matters for the symptoms. How do the notes link location and presentation?
Yeah, it points out specifics like a clot in the lateral sinus often gives you a headache, sometimes feeling like pseudotumor cerebri, that high-pressure headache condition. If it involves the jugular bulb area, you might get jugular foramen syndrome affecting nerves there, and cavernous sinus thrombosis near the eye. That causes pressure symptoms, problems with eye movement nerves, cranial nerve palsies. Lots of nerves run right through there.
It really drives home that knowing your venous anatomy helps predict the clinical picture, like what part of the brain isn't draining properly.
Exactly right.
Let's zoom out again. Epidemiology. How common is IVT?
Sure.
Your notes give some UK figures?
It's definitely rare, only about 0.5% of all strokes. The incidence is estimated around 3 to 4 cases per million people per year. So not common.
But is it more common in certain groups?
Well, yes. While rare overall, it makes up a slightly bigger slice of the pie for strokes in younger people, maybe 0.5% to 3% of strokes in that group. And what really stands out in your notes is the demographic. Women, especially younger women, aged, say, 20 to 35, are affected more often.
That part really jumps out. A stroke or stroke-like symptoms in a young woman. IDT should definitely be on your list, right?
Yeah.
Especially thinking back to those risk factors like pregnancy and the pill.
Absolutely. That age and gender profile is a key thing to remember. It's different from typical arterial strokes.
Okay, now for the really practical stuff for revision. Clinical features. What does someone with IVT actually look like? What symptoms, what signs should make you suspicious?
Your notes list the common ones first. Often a headache, and usually a severe, persistent one. Nausea, vomiting, maybe reduced consciousness. The headache itself is often sudden, really bad, sometimes described like a thunderclap or the worst headache of their life.
And you keep mentioning how variable it is depending on the clot's location.
Exactly. So beyond those general symptoms, the notes get more specific. Seizures are pretty common. About 40% of patients get them early on. Impaired consciousness isn't just mild confusion. It can range all the way to coma. Then you can get focal neurological signs, things like weakness down one side, hemiparesis, maybe weakness in both legs, trouble speaking, aphasia, coordination problems, ataxia, those jerky movements called chorea, or losing part of your vision, hemianopia. Cranial nerve problems too, so maybe balance or hearing issues, like vestibular neuropathy or deafness in one ear, or pulsing sound, pulsatile tinnitus, double vision, diplopia, facial weakness, vision temporarily blacking out. And because the pressure inside the head can go up, you might see papilledema swelling at the back of the eye, which causes visual disturbance.
Okay, this section is definitely high yield for revision. For anyone listening, maybe try grouping these like headache in general, seizures consciousness, focal signs, cranial nerves vision. Might help organize it in your head. Mnemonics could be useful here too.
That's a good approach, just recognizing these signs, especially that severe headache, plus maybe some of the weirder neurological symptoms, is step one.
Given it can look like so many things, the differential diagnosis is key. What else could it be? What do the notes suggest considering?
The big ones to rule out, according to your notes, are ischemic stroke, subarachnoid hemorrhage, brain tumors, and even migraine sometimes.
It's kind of scary how it can mimic these other serious conditions. Makes diagnosis tough initially.
Totally. And the notes actually break it down by syndrome. For sagittal sinus thrombosis, that's a common site. It might show up with seizures, maybe hemiplegia, often causes bleeding infarctions in specific spots like the parasagittal areas. And on imaging, there's that classic sign mentioned, the empty delta sign on venography, where the clot stops the contrast, filling a triangular bit of the sinus.
Ah, the empty delta. Okay, what about cavernous sinus?
For cavernous sinus thrombosis, you have to think about other stuff causing problems there too, like local infection or a tumor. The signs include swelling around the eye, problems moving the eye, ophthalmoplegia, and your notes point out the sixth nerve for outward eye movement often goes before the third and fourth. You might also get trigeminal nerve issues, numbness or pain in the upper face, and even a clot in the retinal vein, affecting vision directly.
And lateral sinus.
Lateral sinus thrombosis, associated with sixth and seventh nerve palsies, so again, that eye movement nerve and the facial nerve. The notes also list a broader range of other causes to keep rattling around in your differential. Things like HIV-related infections, head injury, epidural abscess, pseudotumor cerebri, that high pressure without a mass thing, sarcoidosis, meningitis, especially staph, and SLE.
So for revision, it's not just listing these, but thinking, okay, if I see X and Y, what specific feature points towards IVT over, say, a migraine or an ischemic stroke?
Yeah.
Asking yourself those questions.
Exactly. Those specific syndrome details are the clues.
Right. So you're suspicious. You've considered the risk factors, the clinical picture. How do you actually confirm it? What investigations are crucial?
Imaging is key. According to your notes, the gold standard is MRI venography, an MRI specifically looking at the veins.
Okay, MRV. Any alternative?
CT venography is also an option, CTV.
Now, here's that point you mentioned earlier, which the notes highlight, and it feels really important. A standard CT head scan. It's normal in about 70% of IVT cases.
Yeah, 70%. It's a huge point.
That's massive. So a normal initial CT means basically nothing if you suspect IVT. You have to do the dedicated venous imaging. Definitely a key takeaway for revision.
Absolutely underscores it. Normal scan does not rule it out. Beyond imaging, other tests help. D-dimer levels might be high, the marker for clot breakdown. Your notes mention it can be useful in headache patients, with higher levels maybe suggesting more clot.
Okay, so a blood test can add some weight.
It can, and other bloods are essential. Full blood count looking for infection signs, or maybe high red cells like in polycythemia. An autoantibody screen is needed checking for antiphospholipid antibodies, anticardiolipin. And crucially, a thrombophilia screen must be done to find any underlying clotting disorders. Then, depending on what else you suspect, maybe checking urine for protein, for nephrotic syndrome, or liver function tests for cirrhosis, linking back to those causes. Oh, and one really critical point from the notes, a lumbar puncture is generally contraindicated if you suspect raised intracranial pressure or infection. It can be dangerous, so avoid the LP in that situation.
Right, good safety point. Okay, diagnosis confirmed, maybe found an underlying cause. What's the treatment plan according to the source material?
The absolute cornerstone, the mainstay of treatment in your notes, is anticoagulation, blood thinners. Even though there's already a clot, the goal is to stop it getting bigger, prevent new ones forming, and let the body's own system start breaking down the existing clot.
So how do you anticoagulate?
Typically, the notes outline starting with low molecular weight heparin, LMWH, in the acute phase. It works quickly. Then transitioning to longer-term treatment, usually with warfarin. With warfarin, you're aiming for a specific INR target, usually 2 to 3, to get the right level of thinning.
Okay, so LMWH, then warfarin is the standard path. What about other supportive things?
Simple things like elevating the head of the bed are mentioned, potentially helping reduce intracranial pressure. And obviously, if the patient has seizures, treat those with anticonvulsants.
Got it. Are there any catches or variations to that main anticoagulation strategy?
Well, the notes mention the exact plan depends a bit on complications, the underlying cause, other medical problems. The Royal College of Physicians guidelines, cited in the notes, recommend full-dose anticoagulation usually, unless there's a strong reason not to. Importantly, long-term anticoagulation, like lifelong warfarin, isn't usually needed for everyone. It's generally reserved for people who have recurrent IVT. And for really severe or rapidly worsening cases, sometimes more invasive things like endovascular procedures physically removing the clot might be considered.
Okay. And what about the outlook, the prognosis for someone with IVT?
Generally, the notes say the long-term prognosis is actually pretty good, but some people might have lingering symptoms. The stats given mention recurrence rates around 2.8%, which isn't too high, and overall mortality rates around 10%.
Does the source list things that might suggest a worse outcome?
Yes, it does. Factors associated with a poorer prognosis include being female, having an infection as the cause, developing hydrocephalus, that fluid buildup, having bleeding in the brain as a complication, or having significant motor weakness when they present. That list is probably another good one to flag for revision. These are the patients needing closer watch.
So while many recover well, certain features do signal higher risk.
Exactly. And the notes really emphasize that early diagnosis using MRV or CTV promptly and starting effective anticoagulation quickly makes a big difference, improves the prognosis significantly.
Finally, complications. Even with treatment, what potential problems can arise from IVT?
Your notes list a few important ones. Patients might be left with persistent neurological deficits, ongoing issues with movement, sensation, thinking. Seizures can become a chronic problem. Hydrocephalus can develop. Also, cerebral venous hypertension, ongoing high pressure in the veins, and venous infarction tissue damage from that poor drainage. And crucially, the source stresses the really life-threatening possibilities. Brain herniation, where pressure shifts the brain, or major intracranial hemorrhage. Bleeding, which just hammers home again why catching it and treating it fast is so vital to try and minimize the risk of these really bad outcomes. Thinking about all this, especially how varied it presents and that really high rate of normal initial CTs, it makes you wonder how can future diagnostics get better at catching this earlier, particularly in, say, younger people who just come in with a bad headache. It's definitely something to ponder.
We have covered a huge amount there, a real deep dive into intracranial venous thrombosis, pulling out those key high-yield facts from the source material you gave us.
Yeah, hopefully breaking it down like that, the what, why, who, how, the treatment, the outlook, has made this pretty complex topic a bit clearer and given you some solid points for revision.
Absolutely. Remember, getting your head around these core areas, definition, causes, symptoms, diagnosis, management, it's so important for conditions like IVT, especially because they can be sneaky at first. If you are hitting the books for exams like the MSRA or just want to build your knowledge smartly, having this kind of structured, high-yield content is, well, invaluable. For more resources just like this one to help boost your revision, definitely check out pastthemsra.com.
And if you're looking for some great free MSRA revision materials to get started, head over to freemsesra.com.
Perfect. That wraps up this deep dive. Keep learning, keep exploring.